Hello, everyone. Welcome today to the G4 Alliance in Innovation and Technology Working Group webinar. I co-chair this Innovation and Technology Working Group with Miles, who's unfortunately not able to attend today. But we have some wonderful presenters that actually both Miles and I have reached out to and are willing to join us and do their presentation and bring some really fantastic innovation and technology to the members of the G4 Alliance. So today we actually have three different panelists. The first presenter is Philip Frickman. And Dr. Philip Frickman, and I would like to let you know that he will be presenting for around 12 minutes, and then there'll be a 5-minute Q&A. So after each presenter, that will be sort of the flow of this meeting. So without further ado, I'd like to introduce you to Philip Frickman.
All right, I'm going to go ahead and share my screen here. So, okay, let's see. I need to
We can see your screen.
um, hold on a second. Um, Hold on a second.
There we go. Yep, full screen.
Okay, excellent. All right,
Perfect.
well, thank you. All right, so as Jeannie mentioned, yeah, my name's Phil Frickman. I'm a pediatric surgeon. So what I'm going to talk to you about today is surgical innovation and basically development of a muscle stimulator for anal rectal malformation repair and GP STEP. Um, and GP STEP is abbreviation for Global Pediatric Surgical Technology and Education Project. And so what I want to talk to you about today are basically tell you a brief version of a long story of basically how innovation on a surgical mission for a very specific condition led to an FDA approved surgical device in the US. Also show an example of how, partnering with the right medical device company can support a nonprofit's charitable mission, and then also increase awareness that the MyoTouch muscle stimulator and the Frickman Kimball stimulator stylus for anal rectal malformation repair or ARM repair are available to pediatric surgeons worldwide. So I, I'm t so pediatric surgery is a pretty narrow field, and then if you even narrow it down further down to anal rectal malformation, that's even a relatively small part. However, it has a significant impact on children. The incidence is about 2.5 per 5,000 for excuse me for 10,000 live births, although that's quite variable depending on where you are in the world. There also are a lot of associated anomalies, up to 63% that include vertebral, cardiac, esophageal, and renal anomalies as well. Tethered cords, which affect bowel and bladder function, and also genitourinary anomalies as well. This is a brief schematic of kind of a male and a female version of an anal rectal malformation, where the rectum empties into the urethra in the male and in the vagina or the of the female. There's no opening at the bottom of the where the sphincter complexes are. So these are pretty complex disorders to manage and repair. So it turns out that children with the ARMs are relatively common in RPAs, and RPA is an abbreviation for a resource poor area. And a colleague of mine and a mentor wrote a paper about this and basically said that there's a lot of children with ARMs in the developing world. Partly is there's a reluctance on the part of surgeons there to perform more than a colostomy because many of them don't have the training or resources to do a definitive repair. And so many of these patients that have colostomies are also performed by junior doctors. And so sometimes the colostomies are not in very good shape. Many children wait months or years for definitive repair. And so it creates a bit of a backlog of many patients that need these treatments. So to give you a very specific example. I mean, really the crux of the problem is that this is a baby boy without an anal opening. As you can see, if a baby has a stoma, then the patients often end up in orphanages and can't get further treatment. In our specific situation, we were working in China where these babies could not go on to even be considered for adoption based on the policies. So what our mission did, again, goes back to 2011, was we found that if you do a repair, shown on the left, and you close the stoma, these kids then became eligible for adoption, and then they could get the treatment and the care and a family that they needed. So the need is in this for treatment of this condition is that you need a muscle stimulator. And basically, it's an essential tool for the precise repair of ARMs. And so in 2011, I led a Mending Kids mission to China, which was specifically focused on repairing the ARMs in orphan and abandoned children. And we brought along with us the kind of the gold standard instrument at the time called the Pena stimulator for muscle stimulation. It worked really well, but it had a number of drawbacks. The first was that the probe itself needed gas sterilization, which was not easy to find. The probe was also a very fragile design. The device itself was quite expensive. At that time, about $12,000. It went up from there. And then there are often import restrictions in China and elsewhere, making getting the device difficult. And so my close friend and colleague, Dr. Keith Kimball, who's a peds anesthesiologist, pictured on the right, he and I we found that our pain was limited, and so we had to innovate. And so we improvised a stimulator using a neurostim, which was basically an anesthesia nerve stimulator, EKG wires, alligator clips, and some hypodermic needles to basically makeshift a very low cost stimulator. And we used it side by side on our next 6 patients with the pain in. We found that it actually worked really well. So we published this paper basically showing people how to make this, and that basically it worked equivalently. And we got a lot of positive feedback from the European Pediatric Surgeons Association, and started getting email requests for a low-cost device from all over the world, from Cuba, Indonesia, etc., and demonstrated a worldwide need and demand for such a device. So what we found was that there's an enormous gap between what's needed, that is needed for proper surgical care, that is a stimulator, and the cost of available devices, which was prohibitive to most people. And so the goal became to develop a low-cost muscle stimulator device that could be both sterilizable and durable, so that it could be potentially used by every pediatric surgeon worldwide. So at the time, I worked for Cedars-Sinai Medical Center, and so I duly filed an invention disclosure for my idea, and they decided not to pursue it further and gave it back to me. So I went to actually the father of a patient of mine, Josh Train, who's an engineer, told him what my concept was, the needs and the goals, and he liked the idea and started working with Dr. Kimball and I on this. So in 2013, we formed a nonprofit company in California called Global Pediatric Surgical Technology and Education Project, or GP-STEP. And this is Dr. Kimball and myself a number of years ago on a mission. And the GP-STEP is a nonprofit 501(c)(3) in the United States. We're focused on helping children with anorectal malformations, the pediatric surgeons that care for them, and our goal is to basically develop innovative medical technology and education tools to sustainably support pediatric surgeons in the developing parts of the world. So we went through multiple iterations, and we call this kind of an alpha prototype that you can see is is pretty cobbled together. Basically, the nerve stimulator with some alligator clips and some 3D printed version of a probe. But we got over time, we got more sophisticated, and what we call this kind of our beta prototype that was a what that we call the Frickman Kimball stimulator, which basically the probe portion was built to be both functional and durable. It was a Teflon handle, heat resistant up to about 300 degrees, steam sterilizable, and and all materials were medical grade. However, this is not an FDA or CE approved device. Um, so just to give you some idea about how this works, um, this is what it actually looks like in use in the operating room.
So here's our stuff. Looking at our muscle complexes.
I'm going to turn down the volume a little bit. So you can see that it works. We're able to see, and really what this is used, it's a diagnostic tool for localization of the muscle. Okay. And I'm going to go on to the next picture. So this is what it looks like actually in surgery when we're doing the reconstruction. Is we have to mark the boundaries of the muscle in order to bring the rectum, or what we call the neorectum, down into position. And you can't do this visually. This has to be done with electrical stimulation so that you can see where the muscle boundaries are, which we mark the posterior portion. You can see the muscle twitching there, and basically I'm going to take a stitch and mark the boundary of it. All right. So that kind of shows you that we have to be extremely precise in order to put this together. I'm going to move on to the next one. So what really kind of got us going was actually a grant from Mending Kids who believed in the idea and gave us some money to build these things. And so we created a number of these stimulators and basically gave them away at a colorectal course in Cape Town, South Africa in 2014. This is a picture of 15 pediatric surgeons from 9 countries who received FK stimulators so they can go back and use them and to take care of children in their home country. The way we did it was we would accept a donation anywhere from nothing to $800, kind of based on the World Bank's gross national income quintiles. Over that time period, we deployed about 127 FK stimulators to 49 countries over that time period, and makes a difference. And some of these were used over 100 times, so it served its purpose. We found it was quite effective. We did a kind of a small email survey and found that the surgeons found it both effective or somewhat effective in delineating muscle complexes. And so in 2015, an opportunity arose, and that is that Integrin Neurosciences, who was the company that made the pain stimulator, stopped manufacturing and supporting the device. And so it really opened a market opportunity that we didn't anticipate in the US, basically for a less expensive muscle stimulator for ARM repair. And so we knew we had a great device to fill this niche, and it worked. But ultimately, we needed FDA clearance in order to do this, which of course is a complex and many-step process, which we as a small nonprofit just couldn't do. So we first filed a patent on this, first protect your intellectual property, which we filed in 2015, and ultimately got it issued to us in 2017. This is a copy of the patent here, and this is Dr. Kimball and myself with our celebratory dinner that we actually got our patent issued, which is another step. But once we had that, then we needed to find a commercial partner, which isn't so simple. At that point, I went back to Cedars Tech Transfer, talked to them, and they were impressed with what we had done. And so they said, well, we'll help you see if we can find some companies that can help you. So I set up multiple meetings with 6 medical device companies, all of which told me no, including the company that we ultimately went with. But again, kind of undaunted, a year later, I reached out to the VP of sales of SunMed, and he basically believed in the idea, pitched it to his CEO, and then they ultimately decided they wanted to do it. The other key person is Seth Levy, who was a lawyer who basically did pro bono work for us, but helped negotiate a licensing agreement with us, with GP Step and SunMed. So fast forward a lot of years, we basically got FDA approval, completely redesigned the probe, but got FDA approval in August of 2024, and then we we basically had an agreement. So SunMed actually changed its name. It grew a lot. It changed its name to AirLife, and so that's why AirLife comes up, and you'll see that. And they decided to market the device as MyoTouch with the Frickman Kimball stimulator stylus. And this is the device here. It's small. We had to move from being durable and reusable to single use in the FDA version. AirLife, we partnered with the GP. AirLife partnered with GP Step to make the device. AirLife sells and distributes MyoTouch in North America, and GP Step then deploys the device to surgeons and hospitals in low and middle income countries. This was call it the coming out party at the American Pediatric Surgical Association meeting in May of 2025, and to introduce it to surgeons in North America. So GP Step partnership with AirLife, basically the way we worked this out was royalties support GP Step deployment of stimulators to pediatric surgeons worldwide. AirLife is also pursuing the European equivalent of the FDA for approval for sale in Europe. And so for this, I'm going to conclude and basically show that this is a kind of a summary of how we were able to develop a medical device that's now used in the United States. And one of the important things to me and our organization was that we wanted to make sure that the profits actually didn't go to us as individuals, but rather to our organization, so that we could then support our mission. So I'm just putting up here on the screen kind of helpful links. One is to GP Step, the other is to AirLife, and I'll be happy to take any questions that you have.
Wow, thank you very much, Dr. Frickman. That was fantastic presentation and so interesting to see from the very beginning to now, the evolution of your product and your innovation. I put in the chat box that if anyone would like, they can ask their questions, and there may be some people that are thinking about your presentation and that may end up asking at the end of
Sure.
all of the presenters. I definitely have a couple questions, but I think right now I don't see any questions at the moment.
Mhm.
So we'll continue on, and then perhaps what we do actually now, I'm just thinking on the fly, but we just have all the questions come at the very end,
Sure.
and anyone can answer any questions, and I can direct them to you in the chat as well in case there's any that come up. But thank you
Sure.
so much. That's very,
Excellent.
very
No,
exciting.
my pleasure. And
Very
if any questions come up, I left up so we can be contacted, through the website at GP Step.
wonderful. Thank you. Yes. And actually I also forgot to mention, but this is being recorded, and G4 Alliance has a YouTube channel, and we will be putting this webinar on that YouTube channel, and I'll be sharing the link with you all so that you can share with your community, and we'll be making sure that that gets out to everyone so that this is sort of timeless. People can keep on going back and learning about these innovations if they weren't able to attend. So thank you very much. That was
Excellent.
fantastic, and
My
I've
pleasure.
heard a
Thank you.
lot from Ohana One about you and about your product, and so it's fantastic to hear it in real time. So thank you.
Well, it's very kind. And to all the participants, if realize that in the global health arena, pediatric surgery is a very small niche, and this is even a smaller niche. However, a very kind of important one. So anybody who has colleagues, feel free to have them reach out to us.
Wonderful. Thank you very much.
You
Thank
bet.
you. And next, I would like to introduce you all to Abhi Chandra, Dr. Abhi Chandra, who is with Sabrin Life Pods. And I believe that Abhi is one of the most recent organizations that has joined the G4 Alliance. Is that correct?
Yes, that's correct.
Yes. Yes.
We're
So
very
welcome. And I will turn it over to you to present. And thank you very much for joining us today.
thanks, Jean. Yes, we're very fortunate and very honored indeed to be part of the G4 Alliance. We joined officially the G4 Alliance, I think, about 2 months ago. Um, so everyone, good morning, good afternoon, good evening. Depends on where you are in the world. We know that millions of people die or live with permanent disability because healthcare capability is just too far away for millions of people. And we believe that healthcare should be able to be made, the healthcare should be brought to the patient, not necessarily the other way around, which is what the paradigm is at the moment. So at Sabrin, what our vision is to build healthcare resilience by bringing advanced medical and surgical capabilities much closer to underserved communities through compact and transportable life pods. And we're building resilient systems by deploying these distributed and transportable pods to deliver healthcare capability wherever it's needed. Now, we know that a lot of amazing technology exists already, but we still have billions of people, more than 5 billion people, who cannot access safe surgery or diagnostics or rehabilitation. And we know that patients have to travel for thousands, hundreds of kilometers at least, before reaching definitive care in many places around the world. And these delays are particularly devastating for trauma or for traumatic brain injury or for maternal emergencies where minutes and hours determine outcomes. We've all heard about the golden hour, and we've probably heard about the platinum 10, where those types of emergencies just don't wait for healthcare or capabilities to come to the patient. And the challenge is not just building new hospitals or more hospitals. The challenge is to bring those capabilities closer to where the patients are. And that basically is the philosophy that the LifePod platform is about. Now, delayed access to healthcare capability is the problem, and our response is to try and develop distributed healthcare capabilities. And we're calling this our LifePod ecosystem. Each LifePod is designed to try and support a different phase of care, from preventative healthcare to maternal health or emergency stabilization of an injured patient, or providing definitive care, which includes damage control surgery and then subsequent rehabilitation. So together, we're looking at creating a connected continuum that brings advanced care much closer to underserved communities. And these may be people in remote areas, hostile areas, austere environments, overwhelmed environments, or combat environments. So rather than relying on a single central hospital, which is what the current design for healthcare is, we're looking at trying to have a distributed and resilient healthcare system to support routine healthcare or disaster responses or humanitarian operations, depending on what the mission is. Now, the first example of our LifePod ecosystem is the ObsCare LifePod, and this concept was developed with Professor Errol Norwitz and through the Babson College Global Slingshot Surgical Slingshot Program, in collaboration with an international multidisciplinary team that were from four nations within the African continent. And the objective for this particular project is to try and improve maternal and newborn, especially maternal outcomes for women who are suffering from postpartum hemorrhage by bringing obstetric capabilities closer to these underserved communities through a combination of education, but also bringing infrastructure closer as well. The traditional model involves having expectant mothers having to travel long distances for routine care or emergency assessments. And the OBS Care Life Pod is designed to try and bring emergency stabilization capabilities much closer to where the patient is. And we're trying to demonstrate how this distributed healthcare infrastructure can strengthen maternal health systems. And hopefully we'd be able to get a pilot up and going in Ghana later on this year as in conjunction with the G4 Alliance conference that will be there in November. Another project we're working on is the Trauma Care Life Pod system, and this is trying to address one of the biggest challenges we have for trauma surgery, and that is of time. So we know, I mentioned briefly about the golden hour and the platinum 10. So following severe injury, survival depends on rapid assessment and hemorrhage control and resuscitation and stabilization. In many countries, what happens is the healthcare capability is just a little bit too far away. So what we're planning to do with these trauma care life pods is to provide a compact and transportable environment for frontline healthcare workers to manage damage control, resuscitation, point of care imaging, and rapid diagnostics, and using telemedicine and critical care stabilization. And that may also include, in some situations, damage control surgery to stem hemorrhage and therefore help stabilize the patient and therefore save the patient. Now, this is also quite important because it aligns with the WHO Health Emergency and Disaster Risk Management Framework. And I was fortunate enough to be at the World Health Assembly earlier on this year with multiple people from the G4 Alliance. Now, the third type of life pod that we're working on at the moment is the NeuroCare Life Pod. We know that traumatic brain injury is a leading cause for death and long-term disability worldwide, and the G4 Alliance and the Global TBI Group are actively looking at creating greater awareness within the WHO and making traumatic brain injury into a notifiable chronic disease. Now, the biggest challenges with many of these patients, again, is long delays before reaching a hospital that's capable of performing diagnostics, so CT imaging, or emergency surgery. And the NeuroCare Life Pod is designed to address this gap by combining portable head CT imaging system with an Adelaide-based CT scan manufacturer, and having emergency neurosurgical capabilities and teleneurosurgical capabilities to help decompress, I suppose, patients who've got intracranial bleeds so that they can be stabilized earlier and transferred to a tertiary neurosurgical center for further care. With the next project that we're working on is following on from the NeuroCare Life Pod, and this is our Rehab Care Life Pod. So, and it also is an extension of the Global TBI Group's initiative, where saving a patient post traumatic brain injury is one thing, but they've got a very long and difficult journey subsequent to that. And it's not just neurotrauma, it's also patients with stroke, patients with any kind of orthopedic injuries or vascular injuries or cardiac episodes, as AMI, etc. So rehabilitation services are often very concentrated in urban areas and major cities. So patients who are in rural areas or other at-risk, um, underserved communities do not have access to these. And these rehab life pod, we're looking at trying to bring rehabilitation much closer by combining with some of our collaborators in Mumbai with some of their robotic rehabilitation technologies to help increase the return to normal function for these individuals, whether they be uh, victims of neurotrauma or other types of trauma. And again, this is looking at strengthening the capabilities and capacity of the environment. Now, the much of what we've presented today has focused on emergency and surgical care, but resilient health systems also needs to prevent disease, and we know that non-communicable diseases are the leading cause of death in globally. So cardiometabolic diseases such as obesity, diabetes, cardiovascular disease, chronic renal disease, and fatty liver disease are all very significant contributors of death and disability globally. So this is a project that we are undertaking in rural, remote South Australia at the moment. This is our cardiometabolic risk compression project, which we are looking at deploying into these remote areas and identifying patients at risk and reducing or rather compressing their cardiometabolic risks earlier. So by the time they come to see me as a vascular surgeon and general surgeon, the we can have treatable cases not become um, sorry, irreversible problems, catch them early enough so that they are still reversible. And prevention is part of that resilience capability as well. Yeah, so what we've done is we've looked at multiple different clinical examples of how our platform, the LifePod platform, can work. So the missions are different, but they're all built around a common platform. So rather than developing separate systems for maternal health or trauma care or neurocritical care or rehabilitation or preventative medicine, we've got a modular architecture that can be configured to different clinical missions while sharing a common infrastructure. And this simplifies deployment, it simplifies training and logistics and maintenance, and it makes it easier for governments and other healthcare providers to expand services to their communities over time. And the same platform can also be used to provide routine healthcare and humanitarian operations and disaster responses and be deployed to conflict settings and other scenarios. Now, the purpose is to not just introduce new medical equipment. We think that the value is actually in strengthening healthcare systems and by bringing capabilities closer to the underserved communities and using technologies such as telemedicine, telehealth, we can and educating the frontline health worker and preparing them to do more, we can actually produce strategies or put strategies in place to support safer surgery and improve trauma care and maternal health services, etc. And these objectives all align with the G4 Alliance's mission as well. So we see these LifePods not as standalone innovations, but as tools that can be used by governments or non-government organizations to help patients who are either local or displaced individuals and communities. Our vision is quite simple. If we can bring healthcare capability closer to these communities who are at risk, we strengthen resilience, we improve equity of healthcare delivery, and we save more lives. Yeah, so we have, in my personal opinion, too many people who are experiencing preventable death or lifelong disability simply because these healthcare capabilities are too far away. And we believe that the future is not about making more hospitals, it's actually building resilient healthcare systems where we can bring these systems closer to those at-risk individuals. Thank you for your time, and very happy to take questions whenever.
Thank you so much, Dr. Chandra. That was incredible as well. And it's so interesting to see the two different types of innovations from something that is very incredibly niche and very specific to one specific case, and then all the way casting the lens wide open to seeing how there's different types of infrastructure that can support all of these cases and all the way drilling down. So thank you very much for your presentation. Very interesting, very exciting. If you don't mind putting your contact information in the chat box, and if for some reason you're not able to, please let me know, and then I can also copy and paste it in there, just so that anyone who's joining today or is watching this recording later can reach out to you directly.
Yeah, of course.
And I think we'll just move right along, and then we can save all the questions towards the end. So we'll move right along to Joy Egby, who's with New Digit Health. And we will invite you to do your presentation now, and then we'll open it up to questions at the end. Thank you very much, Dr. Chandra.
Yeah, can you see my screen? Hello?
Hi, we can just see it just says you are sharing screen, but there's nothing
Okay,
showing up yet.
let me go into the screen then. I think. How about now?
Yes.
Okay. Good afternoon, good evening, or good morning, everyone, depending on where you're joining from. And also thank you, Jean and the G4 Alliance for this opportunity to be part of today's conversation and also to share the work we are doing at New Digits. As introduced, my name is Joy, and I am the co-founder of New Digits, and we are an energy company in Nigeria that's electrifying healthcare facilities. A few years ago, we started this journey to address one of the African most urgent problem, which is lack of access to consistent power supply in our healthcare facilities and also medical oxygen. Nigeria has over 40,000 hospitals and clinics, and more than 70% of those hospitals does not have access to consistent electricity and also, of course, medical oxygen. This means that 70% of those hospitals does not have electricity to power essential life-saving devices and equipment. This also means that 70% of those hospitals does not have electricity to operate and deliver quality healthcare services. And it also means that 70% of those hospitals cannot preserve drugs or vaccine for their patients. The list can keep listing it on and on. We already know when there's no electricity, how that can affect healthcare delivery. In addition, because of energy poverty, it has also crippled oxygen productions for medical needs. So a scenario one, this is last year, 2025, there was a case in a state we called Ibadan in Nigeria, Oyo State. It's a city, Ibadan. University of Ibadan is one of the oldest universities in Nigeria, and also you can say is among the top three, even not top one universities in Nigeria. So this is their teaching hospital that service over 400,000 patients annually, was for over 4 months without power. I mean, they were in total darkness for 4 months. This means that for 4 months, there was no quality healthcare delivery. They couldn't do surgery. They couldn't do so many things. And the community and the city that particular hospital serve were unable to receive quality healthcare. And just to let you know, this is a teaching hospital, a federal facility. and one of the biggest teaching hospital in the country. And because of the energy poverty, which has also crippled oxygen production, it's also one of the major issues that many hospitals in Nigeria face, being not having access to on-site delivery of oxygen when needed. And like the last presenter mentioned, the critical moment where that oxygen is needed, if you don't have it available, sometimes in Nigeria, we say we leave the rest to God. So this is also a major problem. And the question may be, why does this problem exist in the first place? For us in Nigeria, one of the major causes for energy poverty, not just in healthcare, but in general, is because of the country has a poor transmission infrastructure, which means that we are producing enough electricity, but we don't have the infrastructure to transmit it to needed people. And also the growing population, we don't have what it takes to transmit this power to the demand of the growing population of the country. So for a typical hospitals in Nigeria, lacks access to electricity, maybe national grid 2-3 hours in a day. And that has led to a lot of deaths in Nigeria. Over 800,000 people die annually due to lack of consistent power in healthcare. And also shortage of oxygen has led to death over 600,000 people annually. And for typical hospital, they spend about $2,000 to $3,000 weekly on diesel generator, on fossil fuel diesel generator, because there's no electricity, so they need an alternative solution, which is diesel. And you may say that's not bad, but for the community healthcare or a rural healthcare, local healthcare who has less than 10 hospital bed, 2,000 to 3,000 is actually a lot of money. And because of that, they are unable to deliver healthcare. Some of these hospitals shut down, or they just, they're just a blackout. And when the patient comes in, you just have to attend to them without, electricity or any other resources. So if you look at this statistic, is just a graph of the hospitals in Nigeria and their current electrical status. You can see that for private hospitals, over 20% of them are shutting down or are shut down because they can't continue to, invest into fossil fuel diesel, because they're a private company, they're not making money, they can't pay their staffs. So some of them just shut down. And for public facilities, they just accept the situation, and there's a blackout every time. 40 to 50% of that is the situation for public hospitals. And for private hospitals who have maybe above 20 beds, you can call them the middle class hospitals. They, invest a huge lot of money on fossil fuel generator to run continuously, and that is literally almost all the private hospitals in Nigeria. If you are running an hospital in Nigeria and you want to deliver healthcare, you need to be, subscribing to diesel generator every single day. So for us, this is a big solution, and it's not just because it's a problem in Nigeria, but because it was a live experience with one of our team, and because of that, we've built a solution we call Just Add Water. It's a regenerative first technology that produces electricity and oxygen for hospitals. It's a all-in-one turnkey system, because the current solution for oxygens in Nigeria are PSA plants, which sometimes can be 50, 80 kilometers, 100 kilometers away. And when the patient needs an oxygen, the life that needed to be saved is not going to wait for 100 kilometers. So this is where most of this casualty comes from. This statistic of number of people dying from oxygen is because of the distance between the oxygen and the patient is too far, that sometimes the life could not wait for the oxygen to arrive, sometimes from another city, another state entirely. And this is the major problem we are trying to solve. So we build all-in-one system, is a turnkey solutions where hospitals can have the solution that's in their facilities. It provides electricity and also medical oxygen on site at the hospitals. And in terms of electricity, the capacity ranges from 15 kilowatts to 1 megawatt of electricity. And for oxygen, the system can produce from 84 meter cube of oxygen to 2,000 plus meter cube of oxygen per day. So the question will be, how does this solution works? It's a first technology. So you know that water is made up of hydrogen and oxygen. So when you split water through the process of electrolysis, you have hydrogen, which we are using to produce electricity for the hospitals, and then oxygen, of course, for medical purposes. So currently, this solution has been deployed in 4 hospitals in Nigeria. We've produced over 200 megawatt hour of electricity. We've generated more than 27 liters of on-site oxygen, and we'll also be able to raise some funding to, to scale this beyond what we're currently working on, and have also some international partners who were able to support us in this project. In addition, we've supported care for over 6,000 patients and reduced emission by over 70,000 tons in CO2. So in terms of what makes our solution different is that of course, we have the fossil fuel generator, which is not sustainable, it's expensive, and is not reliable. And we have the third-party PSC oxygen plants. But for us, we have created only one system that is a turnkey solution for hospitals. And we're also removing the barrier to access this technology, because we know that solution like this can be very expensive and hospitals that cannot afford it. So what we do is to not sell it to them, but give it to them as a service. So they are not buying or paying to acquire it, but they are paying for the services that the solution provides for them. So they pay per use, they pay for oxygen, they pay $0.09 per kilowatt hour of electricity, and also $3.5 per 3 meter cube of cylinder of oxygen as they use. So it makes it more affordable for them to use. You don't have to purchase the technology. For us, the next step, we are taking the lessons that I've learned from the 4 deployments so far to scale the solution to a bigger size for bigger hospitals, from 30 kilowatts to 100 kilowatts, and we are hoping to deploy this in 30 new hospitals in the coming 3 years. And this is our plan for the next 3 years. And this will provide 27-hour 24/7 electricity for these hospitals, and on-site oxygen for patients who needed them. And also we have estimated that in the next for this project, we'll be able to save over 2 million people annually if we're able to deploy 30 of these 30 to 100 kilowatts and the next hospital. Thank you very much. I'm open to questions, and you can reach us on our website, newdigi.tech. And thank you, Jean, for this opportunity to share what we are doing. Thank you very much.
Wow. Thank you so much, Joy. That was incredible. So interesting. And I have so many questions. I have actually so many questions for all 3 panelists. And I've actually put a note in the chat box for anyone who has any questions. They can ask them there. Also, if you'd like to share your contact information in the chat, and if for some reason you're not able to, you can send it to me in the chat, and then I can put it through to the group. I guess what I'll do is I'll start with a question to you, and then we can move through the rest of the group, because I have questions for each. And then if we don't see any in the chat, then I'll just keep on asking questions to use our time, because there's just these innovations are so important and so relevant to this working group and to the G4 Alliance, increasing access to surgical obstetric trauma and anesthesia care. So my first question to you is, and I think you kind of answered it a little bit, was, is it challenging for getting to hospitals to adopt to this technology? And it sounds like one of the ways that you kind of addressed one of the barriers is to have this pay-per-use model. So instead of coming up to them and saying, hey, this is how much it's going to be to invest, it was more like, we're going to give you this technology so that you can try it and then pay per use. Is that something that you've adapted over time, and is that something that you'll continue to adapt in order to get? Is the cost the biggest barrier to getting hospitals to adopt?
Yes. Okay. So the thing is that thank you for that question. It's very important. One thing, apart from the cost, we know that when a new technology comes into market, especially for a healthcare facility, we know that there's a lot of question like, oh, it's a new technology. Am I sure it's, so yes, cost to acquire is one of the major barriers that we face, and that's what actually helped us to shape our business model. Because initially we're going to sell to the hospitals and just like, oh, you can have it and go. But we discovered that it's quite expensive. It costs about $12,000 to have the complete systems, and we're talking about middle hospitals who have less than 20 beds, 30 beds, and they cannot afford this. So what we did was to be able to partner with some, people who can provide us with financial mechanism and can deploy to these hospitals and they can pay as they use. So yes, that really helped.
Mhm.
Then in terms of adoption, it's a new technology, so we also have to keep getting all the licenses needed because it's a medical device in terms of the oxygen itself. So those are the challenges, and we've worked our way around it to ensure that the hospitals that needed them, have access to this technology.
Wonderful. Thank you so much, Joy. And I don't, did you say at the very beginning of your presentation your background and how you came to this to New Digit?
Okay, so actually, my background, I studied maritime engineering at the university, but I have a similar story of one of my auntie dying from indoor pollution from generator fumes. So when I got to the university, it was something that actually carried in mind. So I was looking for how to address this problem because my auntie died from the cause. And also, I was a climate advocate at the time. So I met my co-founder, Derek, at the university. We were researchers at the time. So he also has been in the hospitals where he was admitted and he nearly lost his life because at the time, the hospital he went to, they didn't have electricity and oxygen when he needed it. So we just came back from the hospital and said, we need to look for a solution since we have a similar story. It's from a lived experience. So we came together, we're able to address this problem. Yeah.
Wow. Fantastic. Very, very inspiring. Thank you so much, Joy. Oh, and
Thanks for having
Dr.
me.
Chandra has a quick question, I think.
Yeah, that was fantastic, Joy. I'm just wondering, would you be open? How compact is your system? As in, is it small enough to be in a containerized system, or is it quite large from a physical footprint point of view?
So it depends on the size. What we currently deployed, I don't know if I can share my screen again. It's 15 kilowatts, which is it's good for the hospital that are using them because they have less than 20 beds. So that one can be containerized. So it can be put in the container system because I saw what you are doing, amazing project. It can be containerized, but when it comes to from 50 kilowatts to 100 kilowatts, we cannot put that. That will actually come in a containerized system, but you cannot put it maybe with your kind of container size, depending on your container. If it's less than 40 feet, I believe, I don't think it will work with less than 40 feet container. But for 15 kilowatts to 50 kilowatts, fitting within less than 40 feet container system, but anything above 50 kilowatts will not be able to containerize for another system, except it stand on its own.
What's the smallest size that you have? The reason why I'm asking is I think it would be fantastic if we could look at collaborating on something,
Mm,
deliver a distributed and expeditionary health capability. I think Errol's still on the chat,
Yeah.
but and I'd love to hear about this from you, Errol, as well, because if we're looking at trying to get infrastructure or lack of infrastructure, as you'd mentioned, is a critical problem in so many parts of Africa. And what you're providing is essential for, the basic needs for saving lives. And I think it'll be very interesting if you can, if we can have the smallest possible footprint to provide energy systems, and we can distribute it to rural and remote areas of the world where there's such underserved communities, would be able to save lives for sure. And you're doing amazing stuff. And Philip, you as well. Gosh, your stuff is just phenomenal.
Yes.
yes. Thank you very
Well,
much.
it's
Thank you very much.
I appreciate that. Thank you very much, Dr. Chandra. It's a it's a very much of a niche you know, targeted solution to and again, it's kind of a cheap solution to an expensive problem. And that was, something that's been a bit of a passion project for decade and a half to try to get this figured out. And we've made some progress. So I appreciate that. And again, I hope that this gets adopted not just in North America, but could be adopted anywhere. It could be adopted in Australia, it could be adopted in Asia, it could be adopted anywhere. And then also with the nonprofit arm of being able to basically fund distribution to basically the surgeons and hospitals that basically just can't afford it. So far, it's working. We're just kind of getting off the ground with that phase of things. So.
Can I ask another question? Philip, your product, can it
Mhm.
also be used for traumatic brain injury, for patients with traumatic brain injury to look at how rehabilitation is going? Because obviously, if they've got either traumatic brain injury or spinal
Great
injury,
question.
a lot of
Mhm.
So it's an interesting question. I mean, one of the things that I kind of learned early on, kind of in a crash course of trying to understand like muscle stimulators and nerve stimulators and such. There are, of course, TENS units. There are multiple different types of units that are used. This I don't think is necessarily got the same, power outputs and such that is used for traumatic brain injuries. Where I've seen it used in addition to, kind of the anal rectal malformation repair has been in actually in facial reanimation surgery, where the plastic surgeons use it to identify the muscles and nerves in the face. And again, a very, very niche, very, very specialized type of surgery. Um, but yeah, that's I don't I from my understanding of and again, I'm not a neurosurgeon and I don't understand that side of things, but I don't think because we kind of explored that some and found that the devices were kind of significant, the power outputs and the frequencies were different than what they used. So I have a question for Dr. Chandra, and that is, so it looks like that I think the pod idea is absolutely brilliant. I mean, it's bringing the basically the technology and the facility to the patient, and it's obviously got both military and humanitarian application. What's your experience in deployment? How many of these have has the company that you work with deployed, and what's your experience been?
We are very early stage, Philip. We are at TRL 4/5 at the moment. We've got a surrogate pod deployed in regional South Australia at the moment. So we're based in Adelaide. That has a
Yep,
population around 1 million people. And we've deployed it to a location that's about 8 hours by drive from where we are. And it's classified as a really remote, it's one of the most remote areas within Australia, at least according to the classification system by Monash University's. I don't know exactly what they call it, but anyway. And what we're looking at doing with this particular project is cardiometabolic risk compression. We deliberately stayed away from reduction because reduction implies that it would go down to zero at some point, whereas compression is something that is much more relevant. I think we can compress cardiovascular risk factors, but we can't eliminate it.
of course.
Um, uh, but by the time people come to see me, we're at that irreversible part of the disease process. And it's that 5 to 10% of the population who use up about 80 to 90% of the healthcare resources from a health budget point of view. So, and it's not sustainable. Um, uh, South Australia has 1.8 million people, and in the 2023-2024 financial year, we had budgeted $10 billion. That's with a B, but we overspent that by $1 billion. So we spent $11 billion on 1.8 million people, but we still had ramping, as in ambulances parked outside emergency, large tertiary hospitals. We still had people waiting for 12 hours to see a doctor within the emergency rooms, and we still had patients who were dying outside of the hospital because they couldn't get in. So
Yes.
the problem is increasing, and my understanding from some of the statistics are that by 2035, 1 in 2 people around the world will be classified as morbidly obese. And with that comes cardiovascular disease, so many different cancer problems. And,
Yeah.
it's not fathomable, but it's also not sustainable from a financial point of view. Your question was, what are our experiences? We're still too early at the moment. We're very early in our trials, and hopefully we can get something happening soon, though.
Very good. Thank you.
Oh, yes, Dr. Chandra, I actually had some questions with you for you about regarding partnerships and about it must be a large part of the work that you're going to be doing is really developing all of these different partnerships within country and out of country that will help support you in these pods. We're at the top of the hour, actually 2 minutes past the top of the hour, so I want to honor your time and the attendees' time. I think there's probably going to be a lot more questions. All of your information has been here listed in the chat. I will also be sending out a follow-up with the link to the presentation recorded, as well as the contact information. If anyone is interested in learning more about joining the G4 Alliance as a member, you can definitely feel free to reach out to me and I can connect you with the team at G4 Alliance. But I just can't thank you all enough for taking time out of your busy schedules to prepare just really thoughtful presentations, to share your innovation, to share the work that you're doing, where it's come from the very beginning, infancy stages, even just an idea, to all of a sudden now implementation. And what's so interesting about the three of you all is that the innovations are so unique and different, but they're all complementary to just the overall goal that we're all working to achieve, which is increase access to soda care in countries that it's required, it's necessary, it's a huge gap, and we're all working towards that same goal, even with all different technologies. And so thank you very, very much. I can't thank you enough. And looking forward to future conversations. Hopefully, you'll all join us in our working group again. If you're interested, let me know. But we have another webinar coming up in the Q3 and Q4 of this year, and Miles will be back. And I'm sorry that he's not able to attend today, but thank you all very much for being here, and we'll be in touch soon.
Thank you
Thank
very
you,
much.
Jen.
Thank you all. Bye.
Yeah.
Bye. Bye for now.
Bye.